Ovarian hyperstimulation syndrome is one of the commonest complications of fertility treatment, particularly of ovulation induction. It can happen with any ovulation induction program, whether it's with milder agents like clomiphene citrate, letrozole, or of course, more commonly with super ovulation with gonadotrophins, particularly FSH, in IVF cycles. It is a third space phenomenon where intravascular fluid and proteins from inside the blood vessels leaks out due to increased capillary permeability into the third space, mainly into the peritoneal cavity, in the abdomen, or in the pleural space around the lungs, and very rarely in the pericardial space around the heart. During the LH surge pre-ovulation, there is increased cytokines, particularly vascular endothelial growth factor, that generally is central to the pathogenesis of ovarian hyperstimulation syndrome. There is increased neovascularization, where there is new blood vessels forming in the new around the granulosa cells of the follicles, periovulatory, that probably helps in the formation and the maintenance of the corpus luteum. There is also increased capillary permeability around that time. In superovulation, because of the increased number of follicles, the risk increases even further. With ovarian hyperstimulation syndrome, the LH surge in a natural cycle and the HCG trigger periovulatory in a stimulated cycle often leads to this and worsens the condition. There are generally two peaks, one 7 days after the HCG trigger and 14 days later if a pregnancy happens. Obviously, if a pregnancy happens, the symptoms are likely to be worsened because of the increased level of HCG in the system. During OHSS, there is loss of intravascular fluid and protein, and that leads to hemoconcentration. The blood becomes concentrated, there is less fluid in the blood, and this leads to an increased risk of deep vein thrombosis, pulmonary embolism, and in rare cases, arterial thrombosis. Also, because of the less blood volume, there is less kidney perfusion, and this may lead to prerenal failure. It then stimulates antidiuretic hormones and leads to hyponatremia, so low sodium. That in turn may lead to a stimulation of the renin-angiotensin-aldosterone system, leading to hyperkalemia or increased potassium. Also, because of leakage of protein and fluid into the third space, there can be distension of the abdomen, and ascites, leading to peritoneal distension. There could be pleural effusion, leading to breathlessness, and rarely pericardial effusion. And in extreme cases, there can be Meeks syndrome-like features due to pleural effusion, and sometimes rarely adult respiratory distress syndrome, ARDS, and even death. In the past, risk factors for ovarian hyperstimulation syndrome was mainly looked into, many of which are still relevant, and the main risk factors for developing or predicting ovarian hyperstimulation syndrome are a younger age, history of polycystic ovarian syndrome, high AMH, high antral follicle count, many follicles at egg retrieval, secondary follicles, high levels of secondary follicles at egg retrieval, ovarian edema or free fluid at the time of egg retrieval, and a previous history of ovarian hyperstimulation syndrome. If any of these risk factors or features are present, then one should be cautious as to during an IVF cycle or during a stimulation cycle. There are various regimes that are often followed, which includes an antagonist protocol, GnRH agonist trigger instead of an HCG trigger, instead of HCG for luteal phase support using progesterone, and using egg freezing and delayed embryo transfer rather than allowing a pregnancy to happen. Also, there are other methods like coasting, where FSH levels during stimulation are not increased or even decreased, or abandoning the cycle, or not using an HCG trigger and abandoning the cycle as well. Once ovarian hyperstimulation syndrome, if it happens, all women having egg retrieval and ovarian hyperstimulation, including with milder agents like clomiphene and letrozole, should be warned about the symptoms, particularly about weight gain, and they should weigh themselves daily. When they are seen in the clinic or in the hospital, they should be weighed, and an abdominal girth should be checked. Apart from a detailed history of breathlessness, abdominal distension, discomfort, decreased urinary output, a chest examination, an abdominal examination, and a leg examination of the calf muscles to rule out DVT should be done. Investigations may include an ultrasound scan of the abdomen. One has to be careful with a transvaginal ultrasound scan, particularly in superovulated cycles, taking care not to rupture the follicles. Chest X-ray may be warranted at times, and even an ECG and a VQ scan or a Doppler ultrasound of the legs may be warranted if DVTs or PEs are suspected. Among blood count, a full blood count to look for an increased hematocrit, a raised white cell count in absence of temperature may be relevant. A renal function test with urea and creatinine, liver function tests, albumin are all relevant. Treatment would include, management would sometimes mostly be as an outpatient with proper monitoring, doing blood tests and measuring the abdominal girth and weight and looking for symptoms, but sometimes women may need inpatient admission, particularly if one has severe OHSS. In severe OHSS, one would need to have monitor the urine output, and if it's less than 30 milliliters per hour, one may need a fluid challenge to some increased fluid, particularly sodium chloride without any potassium, to stimulate the kidneys and renal function, and then of course fluid restriction so as not to allow third space collection of fluid. Diuretics are very rarely needed, only in rare cases in acute renal failure to stimulate renal activity. Rarely paracentesis and pleural tap may be needed to drain excess fluid, and in excessive albumin loss into the third space, one may need to replace albumin.